Good afternoon, everybody. Today's topic for PG activity is recent advances in WHO classification of carcinoma cervix as mentioned in the 5th edition of the year 2020. Today, we'll be talking about the anatomy and histology of cervix, the recent advances that have been included in this WHO 2020. We'll be seeing a brief comparison between WHO 2014 and 2020, human papilloma pathogenesis and precursor lesions caused in the cervix. We'll be looking at the histomorphology of carcinoma cervix, followed by the management. Cervical cancer is one of the most common cancers of the female genital tract, which originates in the cervix. It is the fourth most common cancer worldwide and one of the top three cancers in women less than 45 years of age. In the year 2020, 640,000 new cases have been reported and 324,000 deaths have been reported in the year 2020, according to the recent WHO. It is caused by human papilloma virus, and it has played a huge role in the field of scientific research as the carcinoma cervix cells from this woman called as Henrietta Lacks, they had been procured and they had been studied in detail, and that led to the formation of the HeLa cell line, which is the first immortalized cell line. It has around 11 patents and it is still used in the field of medical research. Anatomy of the cervix. Cervix means neck. It is present at the lowermost portion of the uterus and it protrudes into the vagina. So this portion of the uterus is called as the isthmus or the lower uterine segment. And this lower portion is called as portio vaginalis as it comes in contact with the vagina, and it is limited by the anterior and the posterior vaginal fornices. At the center, it has an opening called as the external os. The external os is circular in case of nulliparous females and it is slit-like in parous females. The portion connecting the lower uterine segment with the external os is called as the endocervical canal. Cervix measures around 2.5 to 3 centimeter in nulli gravida. Talking about histology, cervix is made up of fibrous, muscular, and elastic tissue which is lined by columnar epithelium and squamous epithelium. The ectocervix is lined by columnar epithelium showing basally located nuclei and apical mucin. And the ectocervix is lined by non-keratinizing stratified squamous epithelium. It is divided into three zones. The lowermost zone comprises of the basal and the parabasal cells, in that the basal cells are arranged perpendicular to the basal lamina and they are known as the stem cells of the cervix. On top of that is the parabasal layer, which is the actively multiplying layer, and we'll find a normal mitosis in this layer. Above that, the middle layer or the intermediate zone is also called as stratum spinosum, and the cytoplasm of these cells contains Pas-positive glycogen. The superficial most layer is the mature squamous epithelium. Now, in women, in postmenopausal women, in whom the ovarian hormones are not working, this maturation is absent. So only the parabasal and the basal cell proliferation is seen in those females. So because the protective covering is lost, they are more prone to infections and inflammations. The portion or the junction where the endocervix and the ectocervix meet is called as a squamocolumnar junction or the transformation zone. It has a presence of immature squamous cells, and that is the most common site for the HPV neoplastic consequences. So talking about WHO 2014, this book is primarily based on the histomorphological features, wherein carcinoma cervix was divided into three categories: squamous cell carcinoma, adenocarcinoma, and other epithelial tumor. The other epithelial tumors comprised of adenosquamous carcinomas, adenoid cystic carcinomas, adenoid basal, neuroendocrine, and undifferentiated carcinomas. In this WHO, squamous cell carcinoma was further differentiated on the basis of histomorphology in the form of keratinizing, non-keratinizing, basal, warty, verrucous, papillary, squamotransitional, lymphoepithelioma, like etc. Now, there have been a few studies that have been conducted to show the influence of keratinization on the prognosis of squamous cell carcinoma. And in that, they have mentioned that keratinizing variant of squamous cell carcinoma is less radiosensitive and it has a poorer prognosis. In the recent WHO 2020, this book says that the cervical pathology is dominated by HPV infection and its neoplastic consequences. So therefore, they have divided it the epithelial tumors as well as the precursor lesions on the basis of their association with HPV infection. In that, the HPV independent cervical carcinomas tend to be more aggressive. So therefore, this WHO makes an accurate assessment. The main aim of making this WHO is for an accurate assessment of HPV testing and cervical screening programs as well as the HPV vaccinations to see how effective it is in getting rid of the HPV associated carcinomas. That is why this classification has been made. Currently, there is no difference in treatment between HPV associated and HPV independent tumors. And what is expected of a pathologist is that a type of SCC should be documented in the report. For that, HPV testing and P16 immunostaining is essential, but the morphological diagnosis is still acceptable alternative in facilities where HPV testing is not available. Other conspicuous change that they have added in this new WHO is that the tumor types which are common to multiple systems are dealt with together at the end of the book, like neuroendocrine tumors, hematolymphoid proliferations and neoplasia, mesenchymal tumors, melanocytic lesions. All of these have been dealt together at the end of the WHO. And in this WHO, they have classified the information in a very systematic way. In that, they have made a new addition, that is the essential diagnostic criteria and the desirable diagnostic criteria. So whatever is mentioned in the essential diagnostic criteria should be mentioned in the pathology report. And if the desirable diagnostic criteria is present, it makes the report much better. Certain mesenchymal tumors like PCOMA and inflammatory myofibroblastic tumor, they are almost always limited to one site, and therefore they are mostly dealt with in the site where they commonly occur, for example, in the ovary or in the uterus. Speaking of adenocarcinomas, majority of the endocervical adenocarcinomas are HPV associated, but there are another list of insignificant endocervical adenocarcinomas which are also HPV independent. So therefore, the classification was essential into HPV associated, that is HPV-A, and HPV independent, that is HPV-I. The HPV independent type is further classified into gastric type, clear cell type, and mesonephric type. Adenocarcinoma in situ, which is a precursor lesion, has also been divided according to its HPV association. Large majority of adenocarcinomas, the problem is that they tend to appear similar to the endometrioid lesions. So in that case, WHO recommends that we should consider them as HPV-associated adenocarcinomas with mucin depletion first. And according to the essential and diagnostic criteria that are mentioned in WHO, they need to be classified. And also P16 immunostaining has to be done. Few entities have been omitted from this new WHO, that is serous carcinoma of cervix, because there is no evidence that it occurs as a primary tumor in the cervix. Adenocarcinoma not otherwise specified, as all the cervical adenocarcinomas according to WHO should be classified either as HPV associated or HPV independent categories. Lastly, adenofibroma. This is a rather controversial entity because this is mainly has to be reported in a hysterectomy specimen. Its differential diagnosis is benign endometrial or cervical polyp. So there are three conditions that have to be followed: stromal cellularity, then periglandular cuffing, and mitotic activity. There should be absence of these three conditions. Only then this entity could be reported. So it is altogether omitted from this new WHO. Further on staging, this 2020 WHO follows the upgraded 2018 staging system, that is FIGO 2018 staging system. The major changes are seen in the stage 1A. As we remember, the prior stage 1A was based on the depth of stromal invasion as well as the width that was 7 mm. But now they consider it, the assessment is made only on the basis of stromal invasion, as it is mentioned over here, stromal invasion in 1A1 and 1A2. Then the subdivision of stage 1B was made only in two categories, and now it is divided into three categories, that is up to 4 centimeter. And lastly, they have included the lymph node metastasis in the stage 3. It can be diagnosed either by imaging or by pathology report. Let's see the comparison between the two WHOs. The WHO 2020 classification of 5th edition has enlisted all the squamous lesions under one heading. That is the mimics of squamous precursor lesions, that is squamous metaplasia and atrophy. Then the precursor lesions like low-grade squamous intraepithelial region, LCIL and HCIL, And finally, the squamous cell carcinoma according to its HPV association. And wherever the P16 staining is not possible, squamous cell carcinoma not otherwise specified can be reported. Whereas in WHO 2014, they had been divided according to the epithelial tumors, the squamous intraepithelial lesions, then based on the histomorphological features, the squamous cell carcinomas were divided, and finally the other squamous cell lesions were included. Benign glandular and tumor-like lesions in both the WHOs are exactly the same. There are no changes that have been made in that field. Now, the adenocarcinomas, again, in the WHO 2014, it was classified according to the histomorphological types, whereas in WHO 2020, they are classified according to the HPV-associated status. The other epithelial tumors are again included in the glandular lesions, and lesions like neuroendocrine tumors, mesenchymal tumors, melanocytic tumors, and lymphoid myeloid tumors have been dealt with at the end of WHO. Human papilloma virus. This is the most common causative lesion for most of the neoplastic consequences that are seen in the cervix. So Dr. Harold Zorhausen was the first person who said that there was a relationship, or there may be a relationship between the HPV virus and carcinoma cervix. And his research was conducted in 1979, and he finally won a Nobel Prize in his research in the year 2008. So HPV is a double-stranded DNA tumor virus. It has a double genome which is 8,000 base pairs in length. It has a non-envelope virion which measures almost 45 to 55 millimeter in diameter. And it has an icosahedral capsid. A capsid is something that protects the viral DNA. So it has an icosahedral capsid which measures 72 capsomas. It specifically affects the human epithelial cells. And till now, 100 different types of HPV have been found. In these, 40 different types of HPV affect the cervix, and high risk type are 18 and low risk type are 16. But the most common ones that we know are types 6 and 11, which are responsible for the low grade lesions, and they are responsible for majority of the genital warts. They are considered low risk because they do not tend to go beyond the warts. The high risk type, as we all know, are 16 and 18. They have a high risk of transforming not only into cervical carcinoma but also into vagina, carcinoma of the vagina, vulva, penis, anus, upper respiratory tract over a period of 1 to 2 decades. Now, moving on to the life cycle of human papilloma virus. In order to cause an infection, the virus needs to gain access into the epithelium and reach the basal lamina and infect the basal cells. So what HPV does is it gains entry into the epithelium via the microabrasions that are present in the skin or the epithelial surface. Now, why does it infect only the basal cells? That is because the basal cells have specific HPV receptors on its surface, and therefore it infects only the basal cell. For HPV to affect a basal cell or any cell for that matter, it has to be in an actively proliferating state. So whenever HPV affects this actively proliferating or actively multiplying basal cell, it enters the cell, and with the help of its oncoprotein E6, it causes, it limits the cell differentiation. And with the help of E7, it keeps on proliferating the cell. So there is no differentiation and there is proliferation. So the cell keeps proliferating. Therefore, there is immature cell proliferation that we can see. So what happens is when HPV enters the cervix or infects the basal cell, in the case of LCIL, it remains in an episomal form. There are two types of infection that HPV causes. One is the latent type and one is the productive type. So when it reaches this basal cell, it remains in that episomal form and it waits for the cell to stop proliferating and start maturing. So when the cell starts maturing, the viral genome will start proliferating into the cell. So in cases of LCIL, the cell waits, the virus waits for the cell to mature, and eventually the viral cytopathic effects are seen in the superficial layers in the form of the poilocytic effect. Similarly, in the not only infects the cell, but it integrates its genome, viral genome inside the HPV DNA, and it starts multiplying. So here the virus is not waiting for the cell to mature. So there is proliferation of the immature cells, which is seen in the case of HCL and further in carcinoma cervix. It is mainly transmitted through sexual contact, and most people are infected with HPV shortly after the onset of sexual activity. Women with HIV have a 6 times more likely chances of developing cervical cancer. There are three preventive stages that WHO has mentioned. First is vaccination, which is the primary prevention. Second is screening, that is pap smear, and treatment with precancerous lesions. And third is diagnosis and treatment of the invasive cervical cancer, followed by palliative care. So this is the human papillomavirus vaccine. It should be ideally taken in the prepubertal stage by both males and females, and it can be now even taken up to the age of 35. There are two vaccines that are available in the market. One is the quadrivalent and one is the bivalent vaccine. The quadrivalent vaccine is Gardasil, which is protective against the low risk as well as the other one is Cervix, which protects against the HPV type 16 and 18, which is the high risk. Squamous intraepithelial lesions of uterine cervix. Now here we can presume HPV to be like a house guest who has overstayed his welcome and has started using the house for its own purposes, for its own merriment. So similarly, HPV gets incorporated into the basal cell and it gets integrated into the viral genome and starts using the DNA of the cell in order to overexpress its two oncoproteins, that is E6 and E7. E6 and E7 push the immature cells into the cell replicating cycle, and therefore they stop or they block the tumor suppressor genes which are present in the cell cycle, that is P53 and the retinoblastoma gene, which further leads to uncontrolled replication of cell, and then the cell becomes resistant to apoptosis or natural cell death. So as we can see, this is the normal cervical epithelium. We can see all the three layers very nicely. In CIN1, the abnormality is in the lower one third, and we can see a very prominent coilocytic effect. This is a very low power diagnosis. We can make it out very easily. We can see the coilocytic change. There are mitosis that are present only in the upper one third. Moving on to CIN2, the abnormal cells are seen in the lower two-thirds, and there is a few cells which are showing coilocytic change. Mitotic activity is seen in the upper two-thirds. In case of CIN3, which is HCIL, we can see that there is loss of maturation on a whole. There is full thickness atypia, and mitotic activity is seen throughout the thickness. And lastly, invasive cancer, where the squamous cell break through the basement membrane and enter into the stroma. Colposcopy is a medical diagnostic procedure through which we can visualize the cervix, vulva, and vagina. It is used in order to diagnose as well as treat the precancerous lesions. These were the terminologies over the period of years. The older classification for cervical carcinoma, the precursor lesions, involved the dysplasia according to its mild, moderate, severe, and carcinoma in situ. The CIN classification, what they did was mild dysplasia was put in CIN1, moderate dysplasia belonged to CIN2, and carcinoma in situ and severe dysplasia combined were involved in CIN3. This recent WHO and Bethesda system classification have made it even simpler. The three-tier classification is now only a two-tier classification, which involves LCIL, which is CIN1, and HCIL, which involves CIN2 and 3. Low-grade squamous intraepithelial lesion. Again, this is a low-power diagnosis. We can see full thickness atypia, but there is something very prominent here that we can see these racinoid cells, and they are 2 to 3 times the size of a normal nucleus. So these are called as coilocytes. They look like a raisin. This is because there is an undulating nuclear membrane, because of which the cell folds upon itself. So it gives a raisin-like appearance. And this perinuclear halo that can be seen very prominently around the cells is because the HPV damages the cytoskeletal protein, and therefore there is a gap that is seen around the nucleus. P16 immunostaining. Now, P16 is a very important stain, and it's basically a surrogate marker for HPV infection. So, basically, it is supposed to keep the retinoblastoma gene in its hypophosphorylated state. But when HPV infection occurs, there is the E7 tries to block retinoblastoma gene. So, therefore, the retinoblastoma gene causes overexpression. Because of the blockage of the retinoblastoma gene, there is overexpression, and that is seen in the form of P16 immunostaining. So this happens only when the viral genome is integrated into the basal cell. Whereas in the case of low-grade squamous intraepithelial lesion, it just multiplies. It does not integrate itself into the cell. That is why P16 immunostaining in this case is negative. That is, patchy nuclear and cytoplasmic staining indicates that the P16 immunostaining is negative in this case. Whereas in high-grade squamous intraepithelial lesion, we can see full thickness atypia, mitotic activity which is extending up to the upper two-thirds. In case of CIN2, there is a little bit of retained polycytic change that we can note here. And in case of CIN3, that is itself full thickness atypia, loss of maturation. And in both these cases, there is a block diffuse positivity of P16 staining, because in these cases, the viral genome integrates into the host DNA. Moving on to glandular precursor lesions, some of these images are from our institute only. So this is an endocervical polyp. It is a fibrovascular tissue which is lined on all three sides by benign endocervical type of mucinous epithelium, and it shows presence of proliferation of many cystically dilated endocervical glands, and it also has a lot of vascular proliferation. Now, both in such, this is one of the most common finding that almost all of us have come across. Here on the lip of the cervix, we can see a cystically dilated lesion filled with mucus. And on microscopy, it appears like this. It is cystically dilated mucus-filled cyst, and it is lined by flat cuboidal to low columnar type of epithelium. Tunnel clusters, again, they are a commonly noted entity. They are well demarcated lesion. There is lobular proliferation of endocervical glands showing presence of uh, the mucus that is secreted by the endocervical glands. And they are closely packed, but this is a very, very benign lesion. Microglandular hyperplasia, again, this entity looks or appears very florid, and it has the appearance of adenocarcinoma in situ, but it is a completely benign entity, and there is only a benign endocervical gland proliferation that we can see, and stromal chronic inflammatory infiltrate is noted. As we see, these glands do not have any abundant mitotic activity in them, and there is no nuclear atypia that is noted. Now, the diffuse laminar endocervical hyperplasia and lobular glandular endocervical hyperplasia are two entities which are seen towards the inner surface of the cervical endocervical epithelium. And there is a benign laminar proliferation of the endocervical glands. These glands are round to oval to irregular, star-shaped or angulated, as we can see here, very prominent star-shaped glands, but very benign looking with basally located nuclei and apical mucin can be seen here, and there is surrounding inflammatory infiltrate. It could be acute or chronic type of inflammatory infiltrate. Lobular endocervical glandular hyperplasia is a similar entity. Here we can see a central cleft-like space which is surrounded by lobular proliferation of small to medium-sized glands. These are very benign looking glands with basally located nuclei and apical mucin. But in certain conditions, there is something called as atypical lobular endocervical glandular hyperplasia. It resembles the adenocarcinoma, which is gastric type. So it is safer to diagnose them as adenocarcinoma in situ in such cases. Arya-Stella reaction, all of us are familiar with this reaction of the cervix. It is mainly caused by hormonal reaction. It is commonly seen during pregnancy because of reaction of progestins. It is also seen in gestational trophoblastic diseases. In this, mainly the glands are affected. And though the cells look very bizarre and large, they are very benign. And there is a very low mitotic activity that can be seen. There is hobnailing, which is clearly seen in these cases. And this type of Arya-Stella reaction is a close differential diagnosis for clear cell carcinoma. In those cases, on the basis of morphology, how do we differentiate? We will look at the stroma. Because in case of Arya-Stella reaction, the stroma will show presence of decidualization. And in clear cell carcinoma, obviously it's a cancer, there will be presence of desmoplasia in the stroma. Another way to diagnose it is with the help of IHC. We can use napsin A or HNF1 beta to differentiate Arya-Stella reaction and clear cell carcinoma. Moving on to squamous cell carcinoma of cervix. Both HPV associated and HPV independent type have a similar morphology. They could be in the form of a stromal invasion or an exophytic invasion. The histopathology will show presence of keratinizing, non-keratinizing, basaloid, warty, papillary types. But the essential criteria here is infiltrating angulated nests of cells, nuclear pleomorphism should be present, desmoplastic stroma, inflammatory infiltrate, and P16 positivity. In the case of HPV independent, again, it could be a similar type of mass where it could show stromal invasion or an exophytic growth. There is no difference in morphology whatsoever, but there is absence of HPV DNA and P16 staining. It is usually diagnosed at an advanced stage and it shows the higher rate of lymph node metastasis. So this is what a squamous cell carcinoma of cervix keratinizing type look like. As we have entered the pathology residency, this may be the first tumor that most of us have encountered. We can see those nice large polygonal cells with abundant eosinophilic cytoplasm, prominent nucleoli, intercellular bridges, individual cell keratinization. All of that is very prominent. And keratin pearls are a signature feature of squamous cell carcinoma keratinizing type. Now, WHO has also mentioned that in some circumstances, when a very superficial biopsy has been sent, and in those cases where we cannot see the stromal invasion, then we are allowed to report it as stromal invasion must be excluded, and most likely it is squamous cell carcinoma cervix. Next, we have done P16 immunostaining, and here we can see the diffuse block positivity in squamous cell carcinoma cervix. This is the squamous cell carcinoma non-keratinizing type. Again, this is squamous epithelium. There is presence of intercellular bridges, individual cell keratinization, but keratin pearls will be absent from this. Adenocarcinomas. Adenocarcinoma in situ also have been differentiated into HPV associated and HPV independent type. These are the glandular intraepithelial neoplasms, and again their location is the squamocolumnar junction, and they are associated with the high risk type of HPV, that is HPV 16 and 18. So when we look at adenocarcinoma in situ, there are two types. One is mucin secreting and one is mucin depleted. Mucin secreting type has an intestinal differentiation, whereas mucin depleted type resembles the endometrioid adenocarcinoma. It is always restricted to the pre-existing glandular architecture. There could be pseudo-stratified hyperchromatic nuclei, but the prominent feature of adenocarcinoma in situ is that there are presence of apical mitotic figures. They're called as floating mitosis, and they have basal karyorrhexis. They show a block type immunopositivity at P16 immunostaining. So this is what adenocarcinoma in situ with intestinal differentiation look like, and this is what the adenocarcinoma in situ with depleted mucin looks like. They look like very endometrioid type of glands. Again, floating mitosis can be seen and karyorrhexis is noted. Now, adenocarcinoma cervix HPV associated. The adenocarcinoma in cervix, actually it is always differentiated according to the destruction of the stroma. Again, it has the same features like adenocarcinoma in situ, but it will have more exophytic and stromal invasion present. It will have apical mitosis, karyorrhexis, etc. But here we mainly look at the destructive pattern. So this destructive pattern has been differentiated into three types according to the Silva grading system. So it has a histological type pattern A, pattern B, and pattern C. So when we look at pattern A, it will have nice, well-demarcated glands with rounded contours. Pattern B will have those rounded glands, but along with them, there will be multiple foci of single or small. And in pattern C, this is a diffusely destructive pattern. This will have a lot of desmoplasia. So there will be diffusely infiltrating glands, angulated glands, and because of a lot of desmoplasia, they tend to open the glands. So open and broken down glands will also be seen. Solid growth pattern is absent in pattern A and B. It is seen in pattern C. It is called as a confluent growth pattern. It could be in the form of solid, mucin, or papillary growth pattern. Lymphovascular space emboli are absent in pattern A. It could be present in pattern B and C. And complex intraglandular growth is seen in all the three patterns. So this is what it looks like. The pattern A has these well-formed rounded glands with smooth round borders, luminal borders. In pattern B, again, we can see these pattern A glands, but there are other individual glands and infiltrating groups of tumor cells. In pattern C, we can see a confluent growth pattern. and a lot of desmoplasia. Now, so HPV associated endocervical adenocarcinoma, pattern A, B, or C should be the diagnosis. This is an optional thing that we can mention in our report. Histological type is very optional. If we want to, we can mention it in the report according to WHO. Usual type is the most common type. It has a glandular variant, and this glandular variant has a very exophytic pattern grossly. The mucinous type, more than or equal to 50% cells should be mucinous cells, or they can be intestinal adenocarcinoma comprising of goblet cells or enterochromaffin cells and stratified mucin producing carcinoma. This is based on the histological features. Moving on to adenocarcinoma in situ HPV independent type. Now, this is also a quite common entity. It is a non-invasive glandular neoplasm. It will not have those apical mitosis and karyorrhexis. This has a gastric type of differentiation. That is why it is called as a GAIS. So proliferation mainly involves the pre-existing glands. There will be no confluence, no crowding. And mainly there are two markers which can be used to differentiate it from the others. The most common immunohistochemistry markers that are used here are HIC1083 and PAX8, which are positive for gastric type of epithelium. Adenocarcinoma cervix HPV independent. As we saw at the beginning, it is divided into three types: gastric type, clear cell type, and mesonephric type. The morphological features are according to the variants that have been mentioned. Like gastric type will have abundant pale eosinophilic cytoplasm. The cytoplasm has the gastric type of mucin, that is the neutral mucin. So it will be positive for Alcian blue past stain, that is AB pass will be positive and they will appear pinkish red in color. There is a destructive invasion. Obviously, it is a carcinoma and moderate to severe type of nuclear atypia. These are associated with Peutz-Jeghers syndrome and STK11 mutations. And commonly for gastric type, the immunohistochemistry is HIK1083 MUC6 because the cytoplasm stains positive with AB pass. It has the neutral mucin, so MUC6 is positive in this case. Clear cell type, again, the pattern is similar to clear cell variant anywhere else, that is tubulocystic papillary solid type. There are clear cells, they have eosinophilic to flat cuboidal cells, atypical nuclei arranged in these patterns. And again, for clear cell type, the markers are napsin A, HNF1 beta. Mesonephric type, again, this has a Wolffian differentiation. So basically, the glands will be lined by cuboid type of epithelium, and they will contain eosinophilic secretions, just like the ones that we see in BPH. Those eosinophilic secretions will be present in the mesonephric type, and the most common marker for mesonephric type is CATA3. So this is what the morphology looks like. This is a gastric type of endocervical adenocarcinoma. And this is the clear cell type. We can see the tubulocystic pattern and ductular pattern. Management of carcinoma cervix. So firstly, the patient goes for a screening. The most common screening test done is the pap smear. If the pap smear shows presence of dysplasia in the form of L-cell or H-cell, we further go for a colposcopic test. So, and also if the patient presents with an obvious fungating growth on the lip of the cervix, then and there on the colposcopic table or without even the assessment of colposcopy, we can do a punch biopsy. So if the lesion is CIN1, that is L-cell, the patient, we just wait and watch. We ask the patient to come for regular follow-ups. In the case of CIN2, we go for cryosurgery, whereby freezing the cells, we remove the entire zone of atypical cells. In case of CIN3, now we have two options. If the patient wants to conserve the uterus and is desirable of further childbearing, we go for a procedure called as loop electroexcision procedure, or a large loop excision transformation zone procedure, where the entire transformation zone itself is removed. But if the patient's family is complete and is not desirous of further follow-ups, we go for a simple hysterectomy in which only the uterus and the cervix is removed. Next, if on the pap smear, we find that there is dysplasia in this patient, and in the cervix biopsy, we report it as completely normal. So there is a mismatch between the cytology and histology. In that case, we do a diagnostic conization. So cone biopsy is taken and sent for reporting. And therapeutic conization is done in cases of stage 1A1 of microinvasive cervical cancer. In young patients who are desirable of childbearing, again, the patients who have completed their childbearing and are not desirable for further follow-ups, we do a simple hysterectomy. So management, ideally, all these stages of cervical cancer, all of them are radiosensitive. But we do not use radiation therapy for all the cases. We have reserved it only for cases 2B to 4 which are inoperable. The stages that are operable are stage 1A to 1B, 2A. In that, Wertheim's hysterectomy is performed. And stage 1B to 2B and 3B, now a neoadjuvant chemotherapy is performed in which the main chemotherapy agent is cisplatin, which is even a radiosensitizer. And along with that, other neoadjuvant chemotherapy drugs are used. And lastly, basically surgery is preferred over radiotherapy because it causes the fibrosis of vagina. And even teletherapy causes the fibrosis of the ovaries. So the female will go in a postmenopausal phase. So to summarize, we have all the cervical intraepithelial neoplastic lesions. It develops slowly. It is caused by HPV virus and finally leads to squamous cell carcinoma of the cervix. It is prevented by HPV vaccines, as we saw, Gardasil and Cervarix are the HPV vaccines. It can be caught early with screening tests like pap smear, and precancerous lesions are treated with cryosurgery and conization, and cervical cancer is treated with surgery or radiation. These are my references. Cervical Cancer Awareness Month is the month of January. I advise all of you and request all of you to get screened, get vaccinated, and stay safe. Thank you.